Okay, so this next talk will enlighten us about supporting patients with dementia. I now invite Dr. Terence Ong Ing Wei, who is a senior lecturer and consultant physician in geriatric medicine at Faculty of Medicine at University Malaya. Dr. Terence obtained his degree in medicine at the University of Aberdeen, followed by his membership of Royal College of Physicians, subspecializing in geriatric medicine in the UK. He also obtained his master's in biomedical science and also his PhD at the University of Nottingham, UK. Dr. Terence has numerous publications and is a member of both national and international boards and is recipient of several awards to date. Dr. Terence Ong, the stage is yours.
Hello, everybody. It's a pleasure to be here with you a bit virtually. So, in this session, we'll look at how to support patients living with dementia. So, this is the outline over the next 20 minutes. I will start by looking at what is dementia. Then we'll look at how it progresses over time, followed by what challenges specifically affect people who live with dementia and their carers. And at the end, we'll look at what is the role for formal palliative care in this situation. So, what is dementia? Now, for many, we associate dementia as a memory problem, but the brain is more than just a memory organ. It's involved in a number of cognitive domains, and in people who have dementia, it is an impairment in one or more of these cognitive domains, and these domains include learning and memory, language, finding the right words to say, finding the right things to say, executive functioning, which involves planning, organization, aspects of life, complex attention to the ability to say multitask or maintain certain attention at a particular task at hand, motor and social cognition. So this is response to social situations, saying the right things in a social context, and so forth. And these cognitive deficits have to affect and interfere with daily activities. It cannot occur in the context of delirium, which is a very different mental health disorder. And these cognitive deficits are not better explained by another mental disorder such as depression or schizophrenia. How common it is? Well, certainly data from the US report the prevalence of about 1 in 10 in those aged 65 years and over, and in those aged 85 years and over, the prevalence is even higher, affecting 1 in 3 older adults. The Alzheimer's Disease Foundation in Malaysia did put out some figures. So back in 2015, they estimated over 100,000 people in Malaysia living with dementia, and in the coming decades, this number is going to go even higher, although more recent reports quote a figure much higher than what I've put out here. So there are different types of dementia. The most common is Alzheimer's. In many instances, we use the term Alzheimer's and dementia quite interchangeably because they do represent the most common type of dementia seen. But also not forgetting that there are other types of dementia as well. So how does dementia progress over time? So dementia can be separated into roughly 3 stages: mild, moderate, and severe. And what I've done here is sort of list the symptoms that are very much associated with Alzheimer's disease, Alzheimer's dementia, in the mild, moderate, and severe stage. But in general, the mild stages of the disease, many people with dementia still remain largely independent. Uh, Sometimes there may be the odd difficulty with getting the right word or name, or problem with recollecting certain things or doing particular tasks, but by and large they're reasonably independent. In the moderate stage, well, there's a worsening of symptoms in the mild stage. And in addition, things become a lot more difficult in terms of day-to-day activities, uh, you know, communicating, planning things, and families start to notice, gosh, you know, there is a change in your personality, in your behavior. And when we come to the severe stage, and again, there's just worsening of symptoms that were manifesting in the moderate stage. And not just symptoms are progressing, the amount of care that needs to be provided to look after them, that's also gone up. Many patients have problems with sleep-wake pattern, meaning that at night when they're supposed to be asleep, they're awake, and during the day they are asleep. Trouble swallowing, so eating and drinking becomes a very common feature at this stage. There's a vulnerability to infection, and their muscles become very rigid and stiff. So, what are the challenges for those living with dementia? There are a number of challenges, but certainly these are the two that I encounter most often in clinical practice. The first one being behavioral and psychological symptoms of dementia, or BPSD, and the second being issues around nutrition and hydration. So let's look at BPSD first. This is a list of BPSD symptoms, and they range from all the way from agitation, aggression to psychosis. And they form this big syndrome of neuropsychiatric symptoms that becomes a very common feature, affecting up to 90% of those living with dementia. These neuropsychiatric symptoms are distressing for the person and their caregiver. The neuropsychiatric inventory, which is what you can see on this slide, lists down the different BPSDs and its severity, as well as how much distress it causes, as a way that we can use objectively to identify, track, and monitor how it progresses over time. BPSD is distressing. It's associated with poor outcomes, such as a reduction in quality of life, increased care burden, and higher rate of institutionalization. And BPSD itself is associated with mortality. The thing about BPSD is there are no two individuals with dementia who would exhibit the same BPSD in terms of when it starts, how it presents, how it manifests, or even how serious or how severe it is. And that's why when we look at the next slide about how to manage it, it all comes down to a very individualized approach. So as mentioned earlier, BPSD will affect almost everyone with a diagnosis of dementia. As a clinician working in the memory service, one of the things I do try to get across is to explain the trajectory of dementia and to explain that as the disease progresses, BPSD will become a feature of your dementia. Very much like any other chronic disease, whether that's COPD or congestive heart failure, where we talk about how breathlessness and reduction in exercise tolerance will become a feature of the chronic disease. BPSD will be something that will occur uh, among those who do have the diagnosis of dementia. So preparing, getting them to understand how the disease will progress, and so I'll start to introduce concepts and principles about what can be done if any of these features do develop. Now, when BPSD does occur, when it does happen, sometimes it can be very challenging to look after the person living with dementia. And for many instances, BPSD, or at least the behavior, is a manifestation of perhaps an unmet need. So what we try and ask family members, caregivers to do is to ask them, what's the problem? Why are they behaving in a particular manner? Why are they doing what it is that they're doing? Observe and even chart their behavior. Because by charting and by observing, sometimes particular patterns or triggers start to emerge, and that makes it, in a way, easier to try and propose perhaps some strategies to address BPSD. But we come back about sort of exploring the unmet need. It's important sort of from a clinician when we are presented with these challenges in clinic is to think of, right, are we missing something? Is there an underlying physical health component that's triggering this? Is there a cognitive issue? Is there a side effect from medication? Are their bowel and urinary habits okay? Is there a particular environmental stressor, perhaps like the way the light shines onto a piece of furniture, which casts an odd shadow on the wall, which perhaps provoke some of these symptoms? Is there undiagnosed pain? So trying to explore as much as we can, is there something that's not met that we could do something about to try and help the person who's living through dementia, who's living through this PTSD? And again, family members do engage medical colleagues to try and see if there's something that we could help with. But one of the things that we always bear at the back of our mind is, could this also be delirium? Okay, so any acute change in the behavior of someone who has dementia should automatically trigger, right, could this actually be delirium superimposed on dementia? What else can we do? Um, Important thing, and I just cannot stress this enough, is that to manage BPSD, it has to involve a person-centered, very individualized approach. And a non-pharmacological strategy is certainly our preferred option. There's good evidence that these do help in terms of not just managing BPSD, but to reduce the incidence and the severity of BPSD symptoms. So behavior management is what we always talk about in clinic, getting families and caregivers to sort of figure out what works, what does not, what provokes, what triggers. Maybe it's sometimes the tone of the voice, which can be, they could be quite sensitive to. So try and figure out what works and what doesn't. There are strategies around cognitive or emotion-oriented therapies. Something called reminiscent therapy is quite popular, where talking about the past, some perhaps some older gentlemen, they're very proud of the job that they do. So talking about what they used to do doesn't have to be a job. Perhaps about a moment in the past for which they're really, really proud of, something positive in the past they've done. Go back to that, talk about it, and that seems to help with managing BPSD. Some individuals, some people with dementia do respond quite well to sensory stimulation, whether that is through aromatherapy, music therapy, or environmental modification. So, relating whether it's sound, whether it's scent, or whether it's particular environmental modification, that sort of provokes a more positive response from the person living with dementia. And then there are some psychosocial interventions like animal assisted therapy. So this is what pet therapy. Some people with dementia do respond quite well to pets, whether that's sort of fluffy, furry, cute animals. Even exercise is an intervention. Seem to have some pretty good evidence base in trying to help manage BPSD symptoms. But regardless of the approach that's chosen to try and tackle BPSD, it has to target a specific BPSD symptom. And we've listed them in one of the earlier slides. And the intervention not just targets the specific BPSD, but also to the individual. And not forgetting, although we've talked a lot about the care of the person and the BPSD of the person with dementia, can't forget that treatment of BPSD also needs to support the carer themselves. What about pharmacology options? Well, we do have antipsychotics. Uh, the indication has to be targeted at behaviors and distress symptoms that are precipitated by some form of psychosis, some form of hallucination, some form of delusion. And that's where antipsychotics seem to work best. And if we were to use an antipsychotic, it's one of the second generation ones like risperidone or quetiapine or olanzapine. But remember, these medicines do have side effects, quite bad side effects, and they need to be used with caution in those who have Lewy body dementia or PD dementia, Parkinson's disease dementia. The mantra is to use the lowest possible dose for the shortest possible time with regular monitoring built in to monitor treatment response. Other pharmacological agents that we could try are the ones that we use specifically to treat Alzheimer's dementia, such as cholinesterase inhibitors like donepezil, rivastigmine, or even memantine, which targets NMDA receptors. Um, and that by improving or at least delaying cognitive decline would translate into improved neuropsychiatric symptoms. So that's one big challenge that certainly I encounter quite often in clinical practice. The next one is around the issues of nutrition and hydration. Now, as the disease progresses, eating and drinking does become a more common feature. Um, to the point that they start eating simpler food, they start eating less, and they get weaker, they have problems swallowing, and they get drowsy and even less likely want to eat. And eventually, as the dementia progresses, that person with dementia will need some help to be fed. They will refuse food. And towards the more advanced stage, they will start to choke on liquid and solid food. And this strongly indicates that that particular person is now within the advanced stage of the dementia. And more often than not, a discussion is always had around the role of enteral tube feeding, usually nasogastric tubes. Now, when we talk about enteral tube feeding, about NG tube insertion, there are a few questions that need to be raised, and we need to discuss this with the person and their family. Because NG tube insertion, it's a medical intervention. Like any medical intervention, the question is, right, what's it for? What potential harm could that particular procedure bring up? Another important question, and I always feel this comes to the very heart of the decision, is does the insertion of a nasogastric tube and the artificial feeding of nutrition and hydration alter the course of dementia? Because we've talked about harms with any medical intervention. With nasogastric tube, it is traumatic. You're repeating the insertions almost on a monthly basis. It's not comfortable. It's distressing to have something stuck in your nose for long periods of time. People with dementia get very agitated. It worsens their confusion. And sometimes when that gets really difficult, restraints are placed to try and prevent them from pulling on the nasogastric tube. And that itself creates its own problems. Restraints that are too tight cause pressure injury. Feeding through an NG tube can lead to gastrointestinal problems. Reflux is a very common symptom with long-term NG tube feeding. There are guidelines around the role of enteral tubes and the role of feeding and nutrition in dementia. And I've very much just sort of screenshot a number of documents produced by Europeans, American census, even a Malaysia CPG on dementia that I've screenshot on this slide. And they all very much come to the same conclusion. And I'm going to use the American Geriatric Society's position on tube feeding because I like the way they've worded it. And if you follow what it says here, it very much, and along the other documents, come to this position where feeding tubes are not recommended for older adults with advanced dementia. That careful hand feeding should be offered. And hand feeding is at least as good as tube feeding. Tube feeding is associated with agitation, greater use of restraints, greater healthcare use due to tube-related complications, and development of pressure ulcers. it's difficult, and eating is important. It provides nourishment, it reflects love and care, and seeing someone not eat is very upsetting and very difficult to watch. And this is before we introduce specific cultural or religious beliefs into this whole concept of eating and drinking. And as the person with dementia, start to lose weight, they become frailer and weaker and spend a lot more time in bed. It's difficult to not associate that with the lack of food. But what we do try our best to get across to families and caregivers in this situation is the lack of food and the not eating and drinking very much just reflects the underlying advanced dementia. This the dementia that has now progressed to a point where it's manifesting itself in the patient, in the person, by them not wanting to eat or drink. But there are strategies to try and support better oral intake across the different stages of dementia, whether it's the moderate or at the most advanced stage. I've listed some of those things that we do discuss and we do suggest in the clinic, whether it's nutritional supplementation, having snacks in between meals, getting a social element as part of your mealtime practice, different uh, food texture or consistency, if swallowing is a problem, maximizing what's been taken, because remember they have early satiety, so they get full very easily. So we want to make sure when they eat things with the highest amount of calorie, finger food, nothing that's too troublesome, asking what they like, individualizing in that sense, and perhaps different cutlery, because chopsticks might become difficult for some. So a simple fork with a big holder, a big grip might be easier in some instances. Uh, there are a couple of terms that you may come across when we talk about eating and drinking with dementia. You've got careful hand feeding and comfort feeding. Um, and what it is about trying to deliver food safer, cues to look out for, like, removing distraction at meal times, turning off the telly when they're eating, encouraging, when you've got dementia, many do start to pouch food in their mouth, so you have to keep saying, chew, 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 then swallow, otherwise they'll just remain in your mouth. Oral care, don't forget about that, and requirement to train families and caregivers. But as the disease progresses, then it becomes a lot more around comfort feeding, where the role of food is no longer to provide nutrition, but as some means of enjoying little comforts in life, tasting what they like to eat, appreciating these things. And also when we talk about comfort feeding, it's also understand that the dementia has now come to quite an advanced stage already, where the risk of expiration becomes something that families would need to accept is part of the condition. And there is certainly evidence behind careful hand feeding. I've highlighted two here, which came out relatively recently. The one at the top looked at careful hand feeding versus nasogastric tube feeding in a group of older patients who were treated in a subacute medical facility. The study at the bottom was similar in nature but conducted in a care home. And in both studies, both demonstrated that careful hand feeding is safer compared to nasogastric tube feeding in delivering oral intake. So what about palliative care services? At the end of the day, progression is expected in dementia. The issues that are bound to happen, we know they will happen, which is why we can certainly plan support around those things, anticipating what will happen. And what I admire most about palliative care services is how embedded they are within the community, that you don't just exist within the ivory towers of the hospital, that you are there in the community, which means you are at a privileged position to be the intermediary between perhaps where we are within the hospital service, within our specialist clinics, and the needs of the person and the carers looking after the person with dementia. So you provide that link, and also the ability to have those discussions with them about advanced care planning, about what happens when you come to a point where perhaps you aren't able to eat or drink, where mom or dad is no longer able to do certain things. What can we do to support them? So thank you very much. I hope it's provided you with an overview of how to support patients and those living with dementia, as well as their family members, through what is a very challenging journey. So thank you again.
Thank you so much, Dr. Terence. And I know definitely that, there are many of our patients who struggle with dementia alongside perhaps another primary diagnosis that they have. And we struggle also as, healthcare providers to provide the best. So everything that you've shared is extremely useful in this group of patients. Okay, now we will now move on to the next talk in this session.